So we had gone through all of our different mood disorders. We broke down into sort of our main categories of mood disorders, and we left off when we just got to start talking about the factors that might be involved in these mood disorders. So what do we know about why they happen, or what's going on when they're happening? So we're going to be breaking them down into a bunch of different types of factors, the first of which are our biological factors. So unsurprisingly, because we are going to say this for all of them, we see that our monozygotic or identical twins are more similar than our dizygotic or fraternal twins. So sharing more genes means you are more likely to also share the disorder. And this is way more extreme for bipolar disorder than for just depression. So monopolar depression versus bipolar disorder, bipolar is by far much more genetic. So with individuals with bipolar disorder, 50% of them will have a relative who also have that disorder. That is a massive amount. If we look at our concordance rate, so the likelihood of having the disorder if your twin then also has the disorder, it is 5 times higher with identical twins versus fraternal twins. So this is something that's very widely studied, and it seems to have a really strong genetic component. There are some theories that it's involving underactivity of norepinephrine, dopamine, serotonin, a bunch of our different neurotransmitters. So you might remember dopamine and serotonin as being involved in a lot of our reward pathway stuff, or mostly just feeling good. So having low levels of those would be really bad and might be the cause of some of those depressive states. Overactivity of these same neurotransmitters might actually be involved in the manic episodes. So it might be not that you have too much or not enough overall, it might just be the patterns in which they're released or produced or active. But again, we're not quite sure. We also start seeing, especially for bipolar disorder, because it's been widely studied, we see a lot of decreased thickness in different parts of the brain. So we're going to see a reduced density of our neurons in, say, our anterior cingulate cortex, parts of the amygdala, also in our prefrontal cortex. So we're starting to see that certain parts of the brain are actually affected. And there's similar decreases with depression. It's just not as noticeable. We also have some issues with connectivity, so our transmission between different areas. So if we look at the connections between the cortex, our corpus callosum, that bridge between hemispheres, and also our thalamus being involved in our sensory information and where it should go, having a reduced ability to communicate between those areas might be involved in, say, some of these shifts from one form to another, or even just in maybe shifting how we're perceiving our environment or how we're handling information that's coming in. We do see for bipolar disorder with manic episodes, along with that increase in neurotransmitter activity, we do start seeing increased brain metabolism. So the brains are working harder during those episodes, which might actually end up causing the individual to then transition back to a depressive episode because they've crashed after using up too much energy. So it's kind of an interesting back and forth for this disorder. If we get into our psychological factors, a lot of this looks at things like we have personality-based vulnerabilities. So from what we just talked about with looking at stress, we know that certain personality traits can predispose us to being in high-stress scenarios and can end up sort of being an influence on how we frame those scenarios. So negative thought patterns, being pessimistic might predispose you for depression, because those negative thought patterns are very common with depression. Negative self-perceptions can also play a role here as well. So different personality types, things like our neuroticism would be a really important one when it comes to an underlying personality risk. Also things like how, not so much the development of, but once you have the disorder, being an introvert versus an extrovert might influence your social circle, and then might influence how you are impacted by the disorder. So those who are extroverted and have more friends and often interact with others might actually find that that helps sort of buffer some of the negative sides of depression. Or they might withdraw because of depression and then end up even worse. It kind of depends on the individual and the situation. Well, with our psychology hats on, there are some different views that may or may not have a role. Our psychodynamic view, of course, they're going to be looking at childhood effects. So they focus on early traumatic losses or rejections would give us a vulnerability to depression. That is actually the case, but not so much because it's a childhood factor, but more because the more losses, the more stressful traumatic events we have in our lives, the more at risk we are. So that isn't exclusive to the psychodynamic perspective, it's just something they would focus on. From our humanistic view, thinking about how people think about themselves, this is kind of an interesting one where they start looking at how we choose to define our self-worth. And if we're focused on whatever we can achieve or attain, then having problems where we don't meet those goals, where we don't attain what we want, can start degrading our feelings of self-worth, which can lead us into likelihood for depression. So we might start reacting more strongly to failures because we now feel inadequate and like it has changed our self-worth. So we start feeling meaningless because what we had counted on to sort of define ourselves didn't happen or no longer happens. And some of our thought processes, when we look at the thought cycles of those with depression, that lines up with a lot of how they tend to frame things. Which leads us nicely into some cognitive factors. So when we look at depression, we have what's called a depressive cognitive triad, where we have three broad categories of negative thoughts that tend to occur when someone is depressed, and that negative pessimistic framework tends to keep them depressed. But they're going to have negative thoughts about the world, about themselves, and about the future. So their environment, themselves within it, and about what's happening next. And if they can't find hope in any of that, then they tend to be more likely to stay depressed. We find some issues with this inability to suppress negative thoughts with a lot of these mood disorders. So we have a bias where we tend to recall more failures than successes. And we've mentioned before that some of our attributional biases, where we're usually looking at who is at fault, the person or the situation, where those with depression have different frameworks, that's the same thing here as well. So their depressive attributional pattern, success would be attributed to something in the environment, whereas their failures would be something about themselves. And so these kinds of negative thought patterns end up permeating pretty much everything they think about, and it tends to perpetuate those feelings of depression. We can also, of course, have environmental/learning type factors. So we've mentioned learned helplessness a couple of times throughout the semester. This is when we have that previous experiences where bad things happen and there's nothing we can do about it. So when future bad things happen, we don't try to do anything about it. That's very common with depression. And that's often why it can be very difficult to seek help or a diagnosis or treatment or anything like that, because why bother? And depression, if we actually look at the cycle of it and tie it in with some of our learning principles, it actually kind of makes sense, where with this diagram over here, when we develop depression, we're usually going to have decreased reward-seeking behaviors. We avoid others, so you stop doing things that make you happy. You stop talking to people that make you happy. So as those things that would reinforce that kind of behavior go away, you are then going to be less and less likely to do them over time. And so the depression increases. And now we're starting to see that maybe you're behaving moodily because you're in such a bad mood. And now you're going to start alienating others with those behaviors, meaning that you are then even more fully removed from reinforcers and events that might help. So even deeper depression. And then because you don't have positive reinforcement, then it's all cycling together. So a lot of what we find with depression, and at least the depressive side of bipolar disorder, it's all going to lead to this sort of learned cycles. And it can be thought cycles, it can be action cycles. There's lots of cyclical behaviors. And it's one of the reasons why the depressive episodes can go on for a very long time. We also have environmental factors if we're thinking non-learning components. Well, I guess they could still technically be learning components, but parenting style, so how you're raised, can dramatically affect this because it can affect how you think about yourself and the environment. The number of stressful experiences throughout your life would fall under that category. Being exposed to good coping skills or unhealthy coping skills can also affect here as well. And the self-concept that you develop as you get older also plays a role. So there's all sorts of factors that can tie in here. And we can talk about sociocultural factors for our last bit here. So when we start looking at prevalence across cultures, interestingly, the depressive disorders tend not to be as common in Hong Kong and Taiwan versus in the West, but there haven't been a lot of good explanations as to why. It might be a diagnosis thing, it might be a quality of life thing. There's a whole bunch of factors that might get involved. Something to consider is feelings of guilt and inadequacy. That tends to tie very strongly to individualistic cultures, where it's all about yourself and less about the community. And so in those situations, you're going to be feeling more guilty, or you're going to feel failures more strongly because of those social and cultural norms. So that might be part of what's going on. But yeah, there's a lot of factors that can play a role there. And one other sort of oddity is the fact that we've mentioned there's a lot of sex differences in most of our disorders. But if you look at countries that are still developing, so non-industrialized countries, they tend not to show the same kind of sex differences that we see everywhere else. So it might have something to do with where the countries are at in terms of development. It, again, might just be due to maybe there's differences in diagnosis, but just an interesting thing to note while we're talking about different cultures. All right, our next section is our dissociative disorders. So I think we actually end up spending the most time on our mood or affective disorders and the anxiety disorders because those have lots of subcategories. For the rest of these, we're going to be hitting them fairly quickly. So we're not going to spend tons of time on these, just a disclaimer. For example, we're going to talk about 3 dissociative disorders, and 2 of them are only going to be mentioned on this slide. But the first of these is the depersonalization/derealization disorder. So this is an interesting one where if an individual repeatedly feels separate from their body, which is depersonalization, or they feel very separate from their reality, they're sort of feeling like the world is strange, or they're detached from things, that's derealization. If that happens fairly often, then they might receive a diagnosis of this disorder. All of these dissociative disorders are basically looking at disruptions with our consciousness, our memory, our identity, our perception. A lot of it ties into sort of our sense of self as well. So we're having repetitive situations where stuff just feels wrong for some reason. So yeah, that first disorder is you feel either out-of-body experiences fairly commonly, or your world feels strange or unreal or detached. Maybe you're convinced that you're living in a simulation. Next, we get our dissociative amnesia. This is an interesting one. So this is extensive memory loss following some type of trauma, but the way that it works is that they basically sort of separate from the thing that made them feel really, really bad. And it's specifically something that isn't explained by normal types of memory loss. So this wouldn't be because of a head injury or something like that, but this would be they've had a really bad experience and they want to separate from it, so they end up forgetting it entirely. So dissociation is actually one of our coping mechanisms, or our, I'm trying to remember the term. Freud coined it with his, one of his mechanisms. We'll remember it later. But yeah, that's basically what they do, is they're basically mentally fleeing from the thing that traumatized them. And this sometimes comes along with what's called a dissociative fugue, which has been reported and sort of considered separate for a while, but got folded into this because they co-occur a lot. But sometimes people will completely forget their life, especially if it was really stressful, and they'll just up and move and live somewhere else with no recollection of what they left behind. So there are a bunch of different case studies where people had, say, a traumatic event. Maybe they lost members of their family in an accident, and they just disappeared someday and were found decades later living in a completely different place, usually living on the streets, because it's really hard to go somewhere else without a paper trail. But they don't remember who they are or who they were or anything about their life. They just up and move. And then the last of these is dissociative identity disorder, and this one we are actually talking just a little bit more about. This is a very controversial disorder. And this is one of those where, I guess for our definition, an individual has 2 or more distinct personality states within their own body. So each identity or each alter within that system would be unique. And for a long time, people talked about this as, it's probably them just acting. And it's actually been very common in movies lately. A lot of those media representations focus on the potential for violence, which is actually common with a lot of mental disorders. But when you actually start looking at it and why they think it occurs, most of the time it's that somebody is thought to have split themselves into distinct personality types because one of those can take on a role like a protector. So they've had a really, really rough, say, childhood, and they would have an alter, someone who could come in and serve as their face, their protector, in those difficult situations. And then when that difficult situation goes away, then the primary host can return. And for a long time, this is something that they couldn't find evidence for it. There's a lot of ways that they're like, oh, well, people can talk in different voices, they can change their pitch and tone, all of that, so it's easy enough to fake. But they've done tons and tons of research on it as they've started to realize that it's more common than they thought. And there are some really cool studies where they've actually figured out that if they take physiological measurements between different alters, they find that there are differences in respiration rates, their EEG patterns, so their brain waves. There are differences in their eyeglass prescriptions, where some of them need glasses and some of them don't. They will switch handedness, they will switch voice patterns, their handwriting can be completely different. There's one study that they actually found that some alters will be allergic to something and others aren't. So there's a whole bunch of stuff that people can now point to and say, this is really, really hard, if not impossible, to fake. So how sure are you that it isn't a disorder? And it's one of the reasons why it's taken a lot more serious research and it's considered a lot more of a proper disorder nowadays, instead of people just assuming that it's something that's been made up. So it is properly in our DSM-5 now, and there's lots and lots of research that's trying to look into it. There are still those who don't necessarily want to include it because it's very difficult to falsify, but getting more and more evidence on these distinctions, and especially things that would be very, very very difficult to fake, is making people a lot less apprehensive. So that was our dissociative disorders. Next, we get to go into our personality disorders. And here we have another big chunk where each of these is going to get their own slide. Usually only one slide though. But we're going to look at antisocial personality disorder, narcissistic personality disorder, borderline personality disorder, avoidant, obsessive compulsive, and schizotypical personality disorders. So each of these, we're just going to kind of hit the highlights of all of them. But when it comes to personality disorders as a whole, we start seeing sort of people who exhibit stable, ingrained, inflexible, and maladaptive ways of either thinking, feeling, and or behaving. And these are actually fairly common. So if we look at the United States, Canada, and Europe, they estimate that 10 to 15% of adults in those populations could qualify for one of these disorders. So it's a pretty high number. So that's a lot of different things we can look at. We're going to start with antisocial personality disorder. So this is one that has a very, very negative connotation. It's thought to be very, very damaging or destructive to society as a whole. And that's because individuals with this disorder, they tend to experience very little anxiety or guilt. So people would say that they lack a conscience. They don't feel for anything that they, or any damage they cause to someone else. So they don't necessarily follow society's rules because they don't see a reason why they should. So this is usually what people were talking about back when they used the terms sociopath and psychopath. It would kind of overlap very heavily with this diagnosis. Those terms aren't used, or at least shouldn't be used nowadays, but still occasionally get thrown around. But with this disorder, a lot of it is they tend to focus on what's in it for me, but they also tend to be very impulsive. So they lack the ability to think ahead, plan ahead, think of consequences. And so this is one of those disorders that is much more common if we look at, say, incarcerated populations. So I think it's 10 times more likely if we look at just prison populations versus the general public. It tends to be massively overrepresented in prisons, typically because the impulsiveness and that inability to delay gratification of their own needs tends to lead them to violent actions. So as per usual, we have a genetic predisposition thing where there are certain genes that are related, but unlike normally when we just sort of hand wave the fact that there are genetic components, we can actually point to a specific gene for this. So the MAOA gene, the monoamine oxidase A, it's a gene that basically regulates our serotonin activity. And in individuals with a defective version of this gene, they have trouble regulating serotonin. And if my memory serves me correctly, it basically ends up building up. And so having really, really high levels of serotonin in places that you really shouldn't leads them to have very impulsive and usually aggressive actions. And they usually seem to come out of nowhere because they've had this slow buildup, and once you hit a threshold, it's like you flipped a switch and now they're a very different person. So they can be very controlled and calm and manipulative in one moment, and then as soon as we've crossed that threshold, they can be very aggressive and non-planning. So it ends up being sort of a dichotomy of a disorder, which is really, really interesting. We start seeing, of course, if it's an impulsive disorder, we do see MRI differences if we look at our prefrontal lobe for those with this disorder versus those without. We also see some weird, basically lack of communication into that frontal cortex. So it's not just that we see differences in that prefrontal cortex activity, but in everything sort of moving forward towards it, there seems to be a reduction there as well. So it's possible that it's less information is being sent, and whatever gets there is being processed less as well. So yeah, there's a bunch of different factors that are involved. This is far more common in men than women. It's a 3-to-1 where men are far, far more likely to have it. And I can't remember if it's sex-linked or not. But if you are curious about this disorder, there's actually an entire documentary about this MAOA gene. It's called the RAGE gene because, of course, it is for clickability. But it was something that's done by, I think it's the BBC. And they basically travel around the country and interview a bunch of people who have like dangerous jobs. So they go and find some MMA fighters, cage fighters. They go and find a bunch of monks. They get a bunch of lawyers, and they basically test them to see which of them have the disorder, or which of them have the gene, and to see if it sort of matches with expectations. And they end up with a really nice take-home that is having this gene, while it does predispose you to the disorder, it isn't a guarantee. Because the guy who was actually doing the research that found the gene, he has the defective version. But because he had a good upbringing, his environment ended up mitigating that, he ended up not having the disorder. Our next personality disorder is narcissistic personality disorder. So these are individuals who have very grandiose fantasies, usually about themselves. So they think that they are far more important than others would deem them to be. And because of this, they often lack empathy for others because they're a lot more focused on themselves. So their considerations of other individuals, it would only matter if it reflects badly on them. They tend to be a lot more, way too oversensitive to others critically evaluating them. So if somebody tells them that they are being narcissistic, they would feel called out on that. And they typically seek out admiration for others. So they're usually looking for people to sort of give them compliments, tell them they're doing a good job. And when they don't get that, they can react really negatively. Our next one is borderline personality disorder. And this is another one where we tend to see a lot of instability, a lot of cycling. So this disorder comes with a lot of instability in behavior, emotion, and identity. So they tend to have these cycles from very positive to very negative in how they consider themselves and others. So this is a really difficult one. So individuals that have this, their frame of mind changes very dramatically. So we see it in terms of emotional dysregulation, so especially negative emotions. And sometimes this is very self-directed, where they feel really, really badly about themselves and who they are. We also tend to see intense and unstable personal relationships. So because they're so self-critical and their emotions are unstable, they might sort of lash out with anger, but then they might feel lonely and empty because they now don't have those relationships. So they might want to form these relationships, but this instability in their system makes it very, very hard to maintain that. And they tend to also display impulsive behavior. So they're going to be doing things that make them feel good in the moment, but then that emotional dysregulation comes back and now they start feeling guilty and bad about themselves for that as well. This usually occurs in individuals who have very chaotic personal histories. So they usually have had, say, abuse or inconsistent parenting. And so it seems like it might be partially learned, because if you had parents who would sort of maybe lavish you with toys and gifts and praise, and then the next minute they're treating you very poorly, you might see that dramatic switch as normal and internalize it for yourself. They also display something called splitting, basically where they can't integrate the negative and the positive aspects of either themselves or of others. So they end up sort of treating them very, very differently depending on the current framework. And this is why it can be so hard to maintain those personal relationships, because they might speak very highly of you and be your best friend one moment and then absolutely hate you the next with very little understanding of why. And this can be really, really difficult because a lot of times they don't know why these switches are happening. And so they typically tend to view the world as far more dangerous because they anticipate this instability. They see others as being far less helpful, possibly due to some self-fulfilling prophecies or past experiences or just a negative frame of mind. So this can be a really, really troublesome disorder for individuals with it. And though it's usually explained, and I've seen it framed in some of the textbooks as something that's damaging to others, when you sort of dig into it, it's almost just as damaging, if not more damaging, for the individual themselves who has it because of all of that sort of inconsistency. And they typically tend to feel very out of control because of it. But it's another one of those disorders that actually has a very negative connotation. So people tend to look badly upon it. Avoidant personality disorder. This one's really, really short. So for this one, this is when individuals feel extreme social discomfort and timidity, but it's not because of, say, a phobia of social situations. This is usually because it's sort of an internalized framework of, I don't want to go out into social situations. I don't want to interact with others because they have negative sort of internalized feelings of inadequacy. So I won't be good enough, or they're going to see me as a failure. So this is more of a, instead of just panic because of the situation, this is about how they frame it specifically for their view of who they are as a person, hence falling under the personality disorders. But a lot of their fears center around this negative evaluation of others or having people view them negatively. We then also have two at the end here, and these ones keep changing depending on which iteration of the DSM. They keep getting moved around. So our obsessive compulsive personality disorder, it looks on the surface very, very similar to just obsessive compulsive disorder, but it has some slightly different qualities. But our texts, none of the texts went into much detail on it, so I figured I'd include it. But it's basically an extreme focus with perfectionism, orderliness, and inflexibility. But a lot of it is because of the sort of mental processes of, I have to be like this. So instead of it being driven by our obsessions and compulsions, where those parts of the brain are either creating those intrusive thoughts and making us do these actions to sort of alleviate some of the anxiety, here it seems to be more about, because it's personality, more about structures of how you think you should be or how you think you are. At least that's my take home for this one. I will not ask a question about this. I will stick to the obsessive compulsive disorder as its own, but I figured I would mention it because it exists. And then the last one here is schizotypal personality disorder. And just from the name of it, we're going to assume right off the bat there's probably some relationship with schizophrenia, which gets its own entire section later on. But this is a way for them to have put a label on individuals that have very odd, superstitious, sort of eccentric behaviors that they typically ritually engage in. So this might overlap with, say, your mental stereotype of the eccentric professor on campus, who might wander around doing very repetitive behaviors that seem out of the ordinary and odd. And because of that oddness, they might have struggles with their close relationships. They might not be comfortable in social situations, mostly because others tend not to react well to eccentric and odd behaviors. Our next one are somatic system disorders. And these are just interesting, odd disorders. But these are going to be situations where we have physical symptoms with no biological cause. So these used to be called somatoform disorders. This is another one of those where they've moved these around a lot. And there's a lot of, we have no idea what's going on. So one of these, hypochondriosis, this has actually been renamed between the DSM-4 and the DSM-5. It is now an illness anxiety disorder. But if you've ever heard of somebody having hypochondria or being a hypochondriac, it's someone who is constantly sure that they have some illness, and they're always going to the doctor to make sure that they can diagnose it and treat it properly. They're usually having high levels of anxiety, assuming that they're dying from some rare disease. So they get unduly alarmed about symptoms, they're positive that they're ill, and they might even end up inventing symptoms, specifically because maybe they're like, well, my arm feels funny. So they keep touching it, and now it's red because they've kept touching it, and now they're convinced they have a rash. So now they go to the doctor, assuming that they have, say, skin cancer. So that's a lot of sort of cyclical behaviors there. So yeah, this is one of those that's kind of shuffled around a little bit. We also have some pain disorders that fall in here, and this is when people experience pain that is dramatically out of proportion to any of their stimulation. So they might be experiencing pain in the absence of stimulation. I was actually just talking with my previous class. We were discussing phantom limb syndrome, where individuals who have lost a limb often report pain in the area that is no longer there. And from that discussion, we actually looked into what might be causing it. And, maybe in the amputation, there was damage to the nerves, and now we're getting signals that are signaling pain. But they've actually gone in some studies and physically removed the nerves, so there are no connections, and they still exhibit pain. So we're having a report of pain with absolutely no electrical stimulation to cause it. So kind of fits. Physical symptoms with no biological cause. So a very interesting one. And then another really cool one is conversion disorder, which is sometimes also called functional neurological symptom disorder. Conversion disorder is easier to say, but these individuals will have sudden paralysis or blindness or loss of sensation, again, with no physical cause. So this was something that used to be very common. This was something that Freud was involved in. He studied hysteria and conversion disorder. So he had patients who would go blind, and then he'd start delving into their traumas to understand why. But this is something that still happens. So Freud's explanation that, yeah, this is probably some underlying conflict that's causing so much anxiety that you now have symptoms, we know a lot more nowadays. We do know that what they call psychogenic blindness or conversion disorder caused blindness, it can be more common in different parts of the world. And in fact, one of the areas where it's most common, or I guess in one of the populations it's most common, is for individuals who've escaped from Cambodia as refugees. Because that was a very violent area, they have a massive incidence of blindness with no physical cause. So it's one of the places where they study it. And these conditions are very, very rare. Only like 3 cases in 1,000 people ever display this. But we do see higher incidences during wartime conditions, meaning that sort of supports that trauma as a trigger kind of idea. They do tend to run in families which tells us that maybe there's a genetic component, but they're so rare that it's really, really hard to study it effectively. You can't really get an effective sample to see if there's any consistencies because it doesn't occur very often at all. And one of the very, very neat examples of this, so special subtype is called glove anesthesia, which basically is that individuals end up experiencing loss of sensation that covers what we see on the left here. So all of that blue area effectively goes numb. They have no sensation from the wrist down, just like they were wearing a glove. They can't figure out why it happens, and even worse, they're like, okay, well maybe it's like we've lost one of the nerves that's feeding that sensation back. But the colorful stripes on the other side, that actually shows the areas that are covered by individual nerves. So if there was damage to one of those nerves, you'd have numbness for the entire color block. So to have the entire hand go numb, you'd have to have damage to 4 distinct nerves, but you'd also lose the sensation all the way up past your elbow. So there's no biological way that this can happen, and yet it happens more than once, hence calling it one of our sort of conversion disorders. So it's occurring, we have numbness, and you can like poke people and they have no reaction to it, but there's no underlying reason why it could happen. There's a bunch of different theories, so this actually ends up overlapping really nicely with when we start discussing things like hypnosis, where expectations can end up shaping reality. So most people don't have a knowledge of the underlying nerves. So they might assume that if numbness were to happen, it would, gradually climb and cover a certain area. But that's not what happens. So yeah, and we see that our expectations dramatically influence a bunch of stuff, which is really weird. Where, like, we were just looking at a pain study where if you tell people that you're giving them a drug that will help their pain, and there's nothing in it, it's saline, they will experience less pain. If you tell them you've given them saline, then they experience the pain. If you tell them that you're going to give them a drug and then take it away, they actually experience more pain. So you can have like the opposite effects. It's all about expectations. And that's why they think like hypnosis works, where if you tell people this is how hypnotized people act, they then act that way. So there's a bunch of really weird stuff where a lot of it is there's nothing for the underlying physiology that should explain it, but the mind is a very strange thing. So it might just be mind over matter. It's very, very cool. This is something I keep every semester when I see this. I'm like, I want to look this up and see if they've done any research recently. But you have to rely very heavily on case studies because this does not happen very often. But yeah, often enough that they gave it a special name and tried to research how it works and basically came up empty, which is pretty cool. Our next section, so this is a weird one. This section is called Neurodevelopmental Disorders. Different texts will try and slot this under different categories, where some of them actually just call this disorders of childhood, because the assumption is that these are things that occur and start becoming noticeable from a very young age and then persist throughout your lifetime. However, one of the most recent controversies in this field is actually the fact that a lot of people don't receive a diagnosis until much, much later in life. So it seemed kind of weird to just call it disorders of childhood because that misses the whole spectrum of childhood through into adulthood, but also most people, or a large chunk of people, don't receive diagnoses until much later anyways. So we could debate about what we'll call it, but neurodevelopmental disorders kind of fits nicely. So we'll talk about 2 that fit into this category. One is autism spectrum disorder, and the other is attention deficit hyperactivity disorder. So we're probably not going to get very, very far into this, but we'll start with autism. I only get 1 slide for it as per usual, but when we look at autism spectrum disorder, this is another one that's had a massive shift in how it's considered, how it's evaluated, how it's classified with the DSM-5 update. So like we had mentioned, things like Asperger's syndrome, they're no longer used as a term. We've switched over to a more spectrum consideration. And so there's been a large push to change a lot of the terminology associated with the disorder. Some of that is going to lag pretty intensely because society takes a while to change their minds on things. But if we're looking at characteristics that are key for this disorder, it's typically going to be poor communication skills, but there is a dramatic spectrum on this one, where in some individuals, as many as 40% of individuals have impaired language skills. So it can be very common for for individuals with autism spectrum disorder not to speak, or to speak only much later in life. And some people will have perfectly normal verbal skills. It's very, very varied. Even with things like social responsiveness. Some might have lots of difficulty with eye contact, where they refuse to make eye contact and might be really bothered if they do, whereas others might be able to tolerate some degree of eye contact. It might not be their choice, but they might have learned that those are the social cues they need to follow. Sometimes we'll see repetitive and stereotyped behaviors. Typically, it's something that might bring them comfort, or something that they feel better doing over and over again, or it might even be something that they're doing while being completely unaware that they're doing it. And some of those repetitive stereotyped behaviors can actually tie back to our communication things, where something called echolalia, which is basically the repetition of the same word over and over and over again, can tie in there as well. And we typically find atypical thought patterns. Basically, they tend to think about things, the world, other people, themselves, in very, very different ways, which can cause problems when they're trying to understand how other people are acting or why they're acting a particular way. But yeah, as I said, there's a lot of variability here. And again, a lot of changes in our understanding of it. But if we wanted to look at some of our factors that might underlie this, when we look at our biological bases here, we actually do see that it's something that's very common within families. So if we look at our concordance rates, it is much more likely for people who are more closely related to each other to share the diagnosis. And in fact, if you actually, instead of looking at a full autism spectrum disorder diagnosis, if you look at qualities or traits that are similar, so just outside of the diagnosis range, you actually start finding that things like this tend to run in families. So you'll typically find that parents or siblings or even more distant relatives might all have very similar odd patterns of behavior that might not have been diagnosed as autism, but are fairly similar to it. And there's been some neat studies where we look at brains of individuals with and without autism, and we actually start seeing brain anomalies in different structures, as well as differences in patterns of functioning. So activity in different parts of the brain varies for individuals who do and don't have autism. So if we look at under the age of 4, individuals with autism tend to have larger brains, and then they start showing higher levels of neural pruning. So we typically, all of us start with more cells than what we need. It's basically one of those byproducts. We talked about it in our development chapter, where we make extra cells when we're young so that we're sure that all the connections that we need actually occur. And then once we're certain all those connections have been made, we'll then prune back those that are no longer necessary. And it seems that brains of those with autism tend to go even more overboard on this, being larger and then doing more pruning so that we're closer to the same sizes after that 4 years. We also see some atypical development in the cerebellum, so part of our brain that's devoted to movement and balance. So it might actually help explain some of our repetitive motions. It's also related to shifting attention. So it might be why some things may or may not draw their attention as it would those without autism. We also see some differences in hemispheric connectivity. So we know that we have that corpus callosum, that bridge between our two hemispheres. And here we see differences in activation as information moves from one hemisphere to the other. And also atypical activity in the prefrontal cortex, which might relate to some of our atypical thought patterns. So from our description of what types of behaviors are typical for this disorder, a lot of these differences in activation and brain structures kind of lines up logically, which is really nice.